Conidiobolus most commonly causes which type of infection? Options are A. Acute invasive rhino-orbital fungal infection. B. Chronic granulomatous subcutaneous infection of nose and face. C. Pulmonary cavitary disease. D. Disseminated septicemia. Answer of this question is B. Chronic granulomatous subcutaneous infection of the nose and face. Conidiobolus causes Entomophthoromycosis, conidiobolae, a chronic indolent granulomatous infection involving nasal mucosa and maxillofacial tissue. A patient with firm nasal subcutaneous swelling, minimal pain, no bone destruction, and history of outdoor work in tropic most likely has conidiobolomycosis. This infection is can occur in immunocompetent cases where this conidiobolus is prevalent. This Conidiobolus is a saprophytic fungus, belongs to the class Zygomycetes, order Entomophthorales, and it causes chronic granulomatous infection known as Entomophthoromycosis conidiobolae. This infection is caused by most common pathogenic species are Conidiobolus coronatus, Conidiobolus incongruus, and Conidiobolus lamprauges. These are the three species found in most cases of this chronic infection. These species found in soil, decaying plant debris, and tropical and subtropical regions. Common in India, Central America, and Equatorial Africa. It, it is most commonly affect the immunocompetent individuals, outdoor workers, farmer, and laborer. Mode of transmission by the inhalation of spore and minor trauma from the insect bite or small abrasions. If you see clinically, there is subcutaneous infection involving nasal mucosa and maxillofacial region, mainly affecting the skin and mucosa. Characteristically, there is chronic inflammatory granulomatous lesion in the nasal mucosa, facial subcutaneous tissue, and paranasal sinuses. Lead to form painless subcutaneous nodule formation, nasal polyps, facial swelling that are body in duration. And unlike mucormycosis, bone destruction is very rare. Key differences from mucormycosis. Conidiobolus mainly affect immunocompetent while the mucormycosis mainly immunocompromised. Conidiobolus is chronic infection while the mucormycosis mainly having acute fulminant infection. Bone destruction is rarely seen in conidiobolus while mucormycosis it is common presentation. Angioinvasion or vascular invasion is absent in conidiobolus while it is present in mucormycosis. Conidiobolus grow in potato dextrose agar about 25 degrees centigrade. It is rapidly growing. Initially, these colonies are glabrous and waxy. Later becomes powdery due to aerial hyphae formation, and colony maturity occur within 5 days. On histology, they are broad septate hyphae surrounded by eosinophilic material. That material form the splendore Hopley phenomena, and they lead granulomatous inflammation surrounding this eosinophilic material. Treatment of conidiobolus. There is no standard treatment regimen established. You can give potassium iodide, cotrimoxazole, azole antifungal. So you have to use combination of any two so that can be work better. First line treatment is potassium iodide with itraconazole therapy. When there is infection is severe and patient is immunocompromised, you can add amphotericin B. Why amphotericin B is usually ineffective? Conidiobolus belong to Entomophthorales that are not mucorales and having poor in vitro susceptibility to amphotericin B. and shows variable or poor clinical response to amphotericin B. That's why amphotericin B is not quite effective in this infection. But you can add this if there is severe infection of this fungus.